Welcome everyone to the first of our two-part webinar series entitled Digital Maturity in Healthcare, a conversation with the leaders and honorees of the 2022 DigiM Digital Maturity Awards program. I'm very pleased to introduce our panelists today. We have Michael Hasselberg, Chief Digital Officer of the University of Rochester Health Medical Center, Karen Murphy, Chief Innovation and Digital Transformation Officer from Geisinger, Greg Richardville, Chief Digital and Information Officer at Intermountain Healthcare, and Tim Skeen, EVP and Enterprise Chief Information Officer at Sentara Healthcare. Welcome, everyone. All right. What I'd like to do is, for the benefit of the audience, I would love to share a little bit about the Digital Maturity Awards program. I'm Paddy Padmanabhan, by the way, and founder and CEO of Damo.
No, it's okay. This meeting, oh yeah, here. This meeting, I get to just like listen, so I'm really excited.
I'm sorry if you're not on mute, but the audience hopefully will put themselves on mute. Thank you so much. So what I'd love to do is share a little bit about the Digital Maturity Awards program. We launched this program in early Q3 of 2022, and Demo Consulting has been using a digital maturity framework and an assessment model to help health systems do a self-assessment of their digital maturity and the progress that they're making with digital transformation. During the course of the several assessments that we've done over the past couple of years or so, we saw that there was remarkable progress that was being made by health systems. And we wanted to really launch this program to recognize the outstanding work being done by the leaders in the industry. So we had a number of categories, and there's an overall leadership category and a couple of individual categories as well. And I'll share the names of all the winners and the honorees in the next slide. In terms of the process, what we went through was really had invited submissions to the awards program, and the submissions were essentially based on self-reported data for our digital maturity assessment framework. We also appointed an independent panel of advisors who are former CIOs and chief digital officers, and they were very kind and generous with their time to guide us on the program and how to do it right. We took the assessment responses from the submissions. We used a standardized scoring model to come up with the scores and eventually recognize the nominees. And I'm very, very pleased to share with you the list of the leaders and the honorees. We have Geisinger, Providence, and Northwell as the overall industry leaders for digital transformation strategy and execution. And we have Virtua, Intermountain, SCL, University of Rochester Medical Center, Sentara, and Panelists. And you can see a couple of other individual categories as well: consumer digital leadership and technology enablement. At this point, I would like to actually open it up to the panel and open it up with a very general question. First of all, congratulations on being recognized in the leadership categories here. I'd love to get your thoughts on, besides the recognition, what, if anything, did you get out of the participation, and especially through the digital maturity assessment? Anyone?
Yeah, I'll start first, Patty. So first of all, thank you for putting this together and for also creating the maturity model for us all to kind of compare and contrast our growth in this evolution in the digital area. I think for me, we're part of a merged organization now, unifying as one. And so to be able to take a look at both organizations, historically where they were at, the work that we're working on, some of it was very similar, some different. And so for me, going through this exercise not only allowed us to understand how we are in the maturity model, but also taking the best of both and bringing those together. So as we build our program out for next year, this early identification of some of the opportunities that we have as a combined healthcare system is great for us. So we can spread that across all of our 3 regions and 8 states that we serve.
Thank you, Greg. Anyone else?
Yeah, I would just go ahead, Karen.
Go ahead, Tim.
No, I mean, I would just add that I agree with Craig in terms of being able to have an objective assessment of kind of where you are with peers and understanding those, especially peers that have a mixture of size as well as mix of payer versus health system, acute versus ambulatory type of services. So that's been very useful. I just started there at Sentara less than 2 years ago, came from the pure payer world. So really have been the fire hose of understanding provider and hospital space has been tremendous. And first thing we did when I came in was do an assessment, a different assessment around the objective, understanding that. And it was really useful to then kind of see where that progression has moved over the past 2 years, and to get another syncing of that, especially attributed to peers, not just as a broader healthcare industry across all payer providers and payviders.
And Patty, I would agree with Craig and Tim. I think the other part that was helpful to us to go through this exercise was really the benefit of self-reflection for us going forward, not only taking a snapshot of where we are today, but what are the gaps that we may have, or changing in perspective of where we want to put our precious resources. So it was not only a time for self-reflection, but it also enabled us to strategically look at where we want to go in the future.
Yeah, and to build off of Karen, self-reflection was, also huge for us. I mean, over the last several years, we didn't even have time to catch our breath. We had to transform our health system so quickly, and to have the time to reflect on everything we've accomplished, and then to be recognized with other leaders, bigger systems like the Geisingers, the Providences, and Northwells, and to see, hey, we did a pretty good job was, a huge win for our clinicians and across our system.
Thank you all for those comments. Before we jump into the charts, and in today's webinar, I'm going to share a handful of charts, which is based on benchmark data that we've gathered through the assessments that we've done over the years, and also specifically through the awards program. But for the benefit of the audience, just a quick overview of the maturity assessment framework itself, so everyone understands where we're coming from when we're really evaluating health systems and their digital maturity. So our maturity model, Damo's maturity model, is a 4-stage model. Model 1 is really the least mature, and Model 4 is the most mature. Model 1, the attributes of Model 1 organizations are really that they're completely dependent on their EHR platforms for everything digital. Model 2 organizations tend to go beyond the EHR and look at best-in-class tools specifically for clinical access-related programs. And Model 3 and Model 4 organizations are the ones that are making real progress in terms of taking an overall holistic view of digital transformation, taking a multi-year approach, securing budgets and board-level commitments for a multi-year investment program, setting up strategic technology partnerships, setting up advanced data and analytics programs, and really harnessing innovation from the digital health ecosystem, among other things. We also tend to see that from an org model and governance standpoint, the most mature organizations have a group of senior executives working together and collaborating to drive digital forward. And so with that, let me jump straight into the charts. I'll just make a couple of opening comments and invite commentary on this chart. This is one of the benchmark charts that we put together for patient engagement. And as everybody is aware, patient engagement is a very big part of digital transformation and digital adoption. The way to look at these charts for the audience is, you look at the cluster of charts, each bar represents something. So if you look at the cluster on the very left, you see the black bar represents how broadly the initiative has been implemented. So in this case, real-time video visits. And the bar in the middle talks about how important it is to the organization. And the bar on the right, the yellow ones, talk about whether the performance is meeting expectations and what the respondents have to say about whether it's meeting expectations or not. So there's a couple of interesting stories here, and I'd really like to open it up to the panel for the initial comments, because most of you have seen these charts, and your own data is in the charts as well. So why don't you start with you, Karen? Any initial thoughts on what you saw from this chart?
Yeah, so thanks, Patty, for the question. I think at Geisinger, when we look at the level of importance here, we're doubling down not only on the digital ecosystem for patients, but really to be able to deliver care and connect with our patients, given the workforce shortages that we have. I think that imperative has moved up to the top. Quite frankly, we just don't have the people to do the work. And anytime we can use technology as an enabling strategy, we are doing that. So I think in terms of like even maybe next year, the high importance, I think you're probably going to see blue bars across every single one of these initiatives, because that is really what our true north is going to be able to serve our patients. Digitally, I think 2 years ago, we thought about serving patients in a way that of connectedness, but now the imperative has shifted to digital for really to enable us to perform the functions that are so necessary for our patients.
And I think you referred to automation as one of those examples as well. And I see here chatbots. I know you've done a lot of work around the chatbots, and so has Craig. I'd love to hear your thoughts, Karen, on chatbots, and then I'd love to hear Craig's thoughts as well.
I think that's one of the areas that we have been most successful is right before the pandemic, we developed a team which we call the Intelligent Automation Hub. And that team really, I say in the beginning, we did public relations chatbots using RPA, and that was just trying to get information out to the enterprise on what the value of chatbots was. And it required a sales pitch, right? During the pandemic, obviously, we needed far more people that we had on hand, and we resorted to chatbots to actually return results, answer the phones, exponentially increasing our work. Now we, again, due to workforce and the necessary ROI, have really shifted from our COVID work to really looking at business opportunities that will ultimately have a very strong ROI in business processes and also workforce development. For example, we've automated nursing audits. Those audits that nurses have to do for regulation that are really not the kind of work that they want to do, nor do they have the time to do it. But by the end of the year, we hope to have all our regulatory audits completed and the work being done by a digital worker. So has really been very impactful, and we're very deliberate about measuring return on investment to be sure, again, that we're allocating resources in the right place.
Craig, what are your thoughts?
Thanks, Patty. First, just kind of from an overall programming perspective, we look at the patient, the consumer, and the member all kind of as one bucket. So we do have a very large health plan as well. The second bucket is really focusing upon the caregiver or the associate or the employee. That's a bucket. Then a third bucket is all around digital therapeutics or pure digital health, the actual delivery of the care and the processing of some of the work that we do. This chart here, to me, represents that first channel that we have on the patient engagement with the patient, consumer, or the member. And I think for what it pulls to tells me is our focus is correct. We have to have an omni-channel approach to how we engage with our patients or consumers or the members. We have to meet them where they are. They have to have the ability to select what choice they want to engage with us with. And plus, we may talk about a little bit later, understand the whole digital divide and those that may not even fit in any of these categories. How do we make sure that we serve that population appropriately? And what this tells me is similar to what we happen in banking and retail and other things. The most underutilized resource we have in healthcare is the patient. And this provides the opportunity to allow the patient to do the work themselves, whether it's online registration, symptom checking, communications, paying the bill, all the things that we do in other industries for us to be able to impact some of the labor aspects that was discussed previously. We've got to move some of that work to the patient, and or he or she really prefers to do that work themselves. I prefer to pick the time when I want to have an appointment. I prefer to communicate at my convenience when I want to talk to somebody or have a video visit, if I have an opportunity to chat with somebody, and or truly use artificial intelligence to eliminate that human on the other side and let the machine do some of the processing, like we found out with COVID and symptom checkers and things of that nature. There's also going to be some delivery aspects that the machine will be able to interact with the patient. So this for me was a very nice chart to help continue to advance how important the work is and to really provide the tools. It's our responsibility to give that tools and the knowledge and put it into the hands or into the phone of our patients. So I really enjoyed this. On the chatbot question, that took off. That took off quickly with COVID. It was an opportunity for us to truly use very defined knowledge to be able to share with our patients. The labor, we didn't have the labor. We didn't have the opportunity to be able to handle all those calls. And that trickled into a lot of other opportunities, using like Salesforce and automatically going through and contacting, all the people that were on the waiting list, and went through tens of thousands of people in a matter of hours, where that would have taken us weeks or days from a human perspective. So that ability to move really quick, that was a kind of an initial plug for us. And now that is just a common place that how we all want to interact from a service perspective.
Yeah, and I know you've done remarkable progress with your consumer digital initiatives. You talked about self-service options for patients, and I have to draw attention to the chart right to the graph right in the middle on online self-scheduling, which seems to suggest that for the industry on the whole, it is very high importance to be able to offer that service, but it doesn't seem to be doing as well in terms of its performance, nor is it so broadly implemented. Would you have any thought on that?
Yeah, two thoughts. One is we haven't provided the tools in an easy manner, and we still have some protection on the provider side of being provider-centric at times, releasing the schedule and allowing the schedule availability, and to make it simple, reducing the number of appointment types that you have from, dozens down to 4 or 5. That really just kind of preserves the time. So it's a cultural change for the industry to have it be that way. And our responsibility, and with my peers here, is to really provide that ease of use and access to it. Because when you look at scheduling, there's kind of like 2 points to it. One is, was it easy to schedule? And the second, it was just as equally as important, did I get the time that I wanted? It can be very easy, but if my next availability is 3 months from now, it really doesn't meet the need. So from that standpoint, we're kind of tackling both of those together. So that's the way that I would see on that specific example is, our ability to release our schedules and provide the capacity available and the rules so that people can schedule the right appointment type when they do see a provider. And then the second piece of that was really the journey. Healthcare is complicated at times, and there's dependencies and there's journeys when patients go through certain types of diagnosis or treatments. And, the way that we're established historically has been very episodic based. So I'll schedule this and I'll call this department and schedule this, call that department. We have to provide that unified approach so that with the one contact, and hopefully it's not even a call, it will lead to this needs to come first, this appointment second, this one third, and allow the intelligence of the machine to guide the patient through that, kind of more as we have like navigators in oncology and some other specialties. That should all be able to be driven, through automation.
Yeah. Tim, you're very similar to Craig and Karen in terms of the type of organization. You're a large health plan, a health system as well. What do you make of these charts?
Well, I think they reaffirm a number of things that we're finding, right? Really what in addition to what Karen and Craig have talked about that really stuck out to me is the gap between importance and the performance mostly meeting, right? So if you look at three of the bigger gaps, right? Secure patient communication, online self-scheduling, and online check-in, I think what reaffirms is some of the things we're doing. We came out of the gate about throwing digital everywhere and trying to drive it out there. We had a lot of companies throwing digital stuff at us and trying to get it thrown against the wall and seeing what would stick. And what we're finding is part of our problem, and that's not always an easy discussion that I've been having most recently, is that we're not doing the proper business process reengineering of the operational environments, the physical, so to speak, that supports this digital type of solutioning. So if you think about online self-scheduling, Craig touched on it a little bit. Are you reorganizing the way you do care practices, the way you do open schedules, the way you have staffing and different levels of staffing that can handle different things? If you don't have that constructed well, then digitizing that is going to typically be unsatisfying to the consumer. Similar with online check-in, right? So online check-in, it's not just about, hey, I got all these digital forms, I throw it on an app, and magically everybody engages and it works perfectly, right? So this is about us also thinking about in our facilities. Do we need at the elbow folks? Do we need young digital first folks sitting side by side in our check-ins while they're waiting to get in to help them with that digital check-in or to help engage them with our digital environment so they're comfortable learning that and not trying, and engaging it. So there's a physical aspect of how you make sure that that's going to be optimized. And then secure patient communication. I mean, it's the same thing to a certain extent, because if you're not constructing the physical operation environment and the staffing to be able to have the right interaction at the right time through that secure communication, once again, it's not going to be satisfying. And people are going to disengage very quickly, right? It's just like anything in the retail space that's digitally enabled. It's not, you don't take too long to get frustrated before you just give up and go to another place, right? So I think that's the same thing that really struck out to me, is that obviously we need to be better technologists in making it simple and intuitive and easy as possible. But we can't shortchange the fact that they're an operational physical component about how we deliver digital services. And if we don't fix those behind the scenes in the back office, then it's not going to be effective on the front end.
Yeah.
Patty, I'd like to jump in just for a second. I want to comment on something that Tim said, which I find so true. We had an example recently where one of our senior executives, where he went ahead and filled out all his e-forms, ahead of the appointment. Like 6 o'clock that morning, went in for his appointment at 8 o'clock. And as opposed of, either being roomed or saying, you'll be checked in shortly, the registrar then went through online versus given a clipboard, but went through online to validate everything that he had just completed a couple hours earlier. So if you don't change that operation to match what you're doing, you're not getting the efficiency nor the satisfaction and the experience that you want.
Michael, any thoughts from you?
Yeah, when I look at this array of bar charts, I think it tells the tale of where we've been over the last couple of years. So when I look at kind of the left side of this chart, I actually identify this as being really focused on access, and it's really that kind of digital front door. And we were at a time during COVID where we had to create a new way of our patients accessing our services. And as you kind of move along this slide here, you start to get into more engagement type technologies, like the chatbot. Interestingly, when I'm looking at one of our colleagues on the panel was discussing the biggest gap with the online scheduling. Like I think we all get that, our patients want to have that kind of open table experience and, schedule an appointment. And that was an area that at the University of Rochester, we didn't have that offered before COVID, and we needed to stand it up. Actually, the problem that we had was our data was really bad on our end. So we didn't really understand, what types of patients our providers like to see. We didn't have it really organized of, which providers spoke multiple languages, which providers accepted what insurances. All that data was disparate, and it was not aligned with the terminology that patients use to search for providers. And so, when I now flip to chatbot, and you see chatbot low importance on this chart, but actually really performs and meets metrics, we actually utilize chatbot first so we could clean our data up. So we needed to understand, how were our patients searching for our providers when they wanted to schedule an appointment? What was our data throwing back at the patient, which we knew was getting it wrong like 80% of the time? And then how could we iterate and clean our data up to the terminology that patients use to find a provider? And once we did that, it really unlocked online scheduling for us and some of that more forward-facing front door. So, we actually use chatbot in a way of a mechanism to clean our data up, to unlock that front door.
Interesting. Well, why don't we discuss a couple of other related charts as well? The next one is really provider enablement, which I kind of see as the flip side of the coin. We've talked about patient engagement, but it's also equally about provider enablement. Any thoughts on this? I'll open it up to the panel.
Well, I mean, all I would comment, and it's we talked about needing to get the operations re-engineered. Obviously, with COVID, everybody had to quickly get providers engaged to deliver and have virtual consults and other things. And then what we learned about was a couple different things. What are providers' preferences around how they want to engage digitally when they're providing those services? And that was missed really badly. And we had a bunch of technology that we drove them one way, and then they started going to other ways, including things like FaceTime, anything to start doing some of this, which wasn't captured in the right way, wasn't secured in the right way. And but in the end, it drove us forward probably, a number of years. I think somebody at a conference that Michael and I were last week said 10 years. I don't know if it accelerated 10 years, but it accelerated a lot with saying, hey, we actually need to take this more seriously about how we're going to build up these ecosystems and facilitate that. And I think what you're seeing here is providers are just as important to the equation as the patients and how they engage, to make sure that providers will engage in the right way and to make it easy for them. Otherwise, they'll lose focus and drive away from it also. So it's just as big of a problem. And I know, we talked about, Craig and I, with having the large member payer side, that three-legged stool. I mean, that's another piece of that engagement, is how do you not also confuse, especially in that environment where you have your providers, the digital solutions, and your health plan services all fully engaged. That's another level of frustration that can be even worse, even though you own all sides of that, if you're not thoughtfully understanding the full value chain and the journey map between all those different touch points, and they all intersperse, right? And so that's some of my initial thoughts on the chart.
I think when I look at this, I think we have to go back to the lessons that we learned with EHR implementation. So we went into physicians' offices and we said, we're going to make it better. We're going to make it easier. It's going to be better quality. And none of those things ever came to be, and still aren't there, right? It's harder for the doctors. They're spending more times on the computer. I think we really have to look at those lessons and say, as we're rolling out these strategies, because we already set the precedent with the HR. I think unless we make it slick and embed all of these technologies in workflow, I think we're going to have a really hard time at continuing to grow them, because they're already overburdened with technology in a way that isn't necessarily helpful to them.
Let's talk about that. I think physician burnout has been a subject of discussion for a while. Technology arguably has contributed to the problem, but technology, ironically, can also be a solution out of the problem if implemented right. So I'd love to hear the panel's thoughts on where are the nuggets of success? What may be one or two best practices to make sure the technology doesn't become an additional burden to physicians, while trying to help the organization meet its goals. Anyone want to take that?
Yeah, I'll start out. I want to first comment on this slide though, Patty, 'cause I think it's important. It's subtle, yet it's really important that you call this enablement versus engagement. Now, I think that leads to your burnout question, because this isn't only about digitizing what's good for the provider, how they engage with the patient, but to Karen's point, a lot of the things that have happened over the last 2 decades have created a burden for the providers. And so the enablement part to me is what's really key. How can we make their life outside of the actual engagement, all the regulatory and documentation and all the other requirements that they have? There's been a lot of things done on the provider side. An example for us has been the Microsoft/Nuance ambient intelligence, the DAC system. We were an early adopter of that 4 years ago, and now we're starting our full system rollout. But some of for those that elect to choose it, and again, that's an important piece too, it's not a requirement. We're not forcing anybody to do anything with this tool. But for those that do elect to do it, we've seen some very positive outcomes. Things that range from a provider saving 3 to 4 hours a week on documentation. And we can show that because we can, monitor all of the time that they're in the system and what they're doing. And we can see how that tool has now reduced that time. Some have chosen to have a better work-life balance and use that time personally. Some have chosen to see 6 to 7 more patients a week. But that's their choice to do that. So none of this is going to be a requirement. That to me is an example, though, of the system utilizing artificial intelligence to interpret the conversation between the patient and provider and create that medical note, create the suggested billing codes. All that's happening in the background while the provider continues with their day. And what we found was with that savings, not only with that, but also the accuracy of the documentation and what occurred during that visit was higher. So as opposed to maybe at lunchtime, I do my documentation, or at the end of the day, where I don't maybe possibly remember the whole conversation that did occur. This is all real time happening, and then he or she gets it just to review. So to me, that's an example that would reduce the burnout, increase the efficiency, increase the effectiveness, and for the patient, they also kind of see it as an advanced technology, that we are utilizing a tool that not everybody does, that kind of separates us of being more innovative, more creative, and more on the front edge of change.
Yeah. Tim and Craig, I'd like to ask you this, since you also have the CIO title. Is the technology ready for prime time? Specifically, when you talk about voice or AI, what's your position on that? With some of these emerging tech in particular.
I'd say the tech has been there for a long time for a lot of, we'll say, foundational things to solve. If you leap to the other end of the spectrum to say it's about advanced AI and advanced machine learning, untrained, unsupervised learning. I mean, if you're trying to say, hey, I want something to magically solve a silver bullet and I'm looking for the tech to do that, I think you're looking in the wrong place. I think we've had the tech and the ability to do data interoperability, which is critical as the foundation to all this. And I think, as Michael actually reaffirmed, we've had that for a long time. I think how we operationalize it, how we do it in the workflow, how we make that interconnect seamless as the pane of glass to both providers as well as to the consumers, I think is the problem. And we've explored a couple different areas, and we'll continue to, right, where I think in that far side of that spectrum, where it's kind of about convincing the organization to put 6 or 7 or however many irons in the fire, so to speak, to let those things develop. And just like a private equity investor would do, say, hey, 1 or 2 of these are going to be unicorns and the rest aren't. But you have to, I think, so having that and allow that to kind of, continue to grow while you look at that foundational pieces where you have plenty of technology tools in the bag to organize within the environment and really improve tremendously both the provider and the consumer's experience in this environment and link them together. And I think, one of the reasons I came to Sentara, right, was getting away from just, hey, being a payer, trying to figure out how to have members effectively interact with the provider system, has come to an environment where half our business is provider care delivery and half our business is health insurance for members, is figuring out how do we connect those two, which weren't even connected internally when I got here and still have a long ways to go. How do we connect those two just to make life simpler for people to access and understand what's going on in their environment, instead of worrying about what's happening to them? How do they get what they need when they need it, which is obviously not just acute services and not just catastrophic insurance. It's about health and wellness around a broad spectrum. And I think, that's what's exciting to me. And as far as tech, I mean, maybe I'm naive, but I think we've got plenty of tech. We don't have necessarily plenty of collaboration and operational workflow optimization and seamless integration to service the providers and the consumers in a way that they should be.
Yeah, Patty. So on the voice side, your questions on voice and AI. On the voice side, I think many of us have adopted voice as a user interface for years, and so that being a very accepted practice, whether you're on the provider side or the patient side, many of us interact with Alexa. We turn our lights on and off. We control things in our car that way. That's been around. I think that's going to continue to advance, because that's a very simple opportunity, because many of us use voice as a way if we're in person. So why don't we just interact with the machine that way? On the AI side, I'm a little more optimistic. I actually think it's accelerating fast. I think part of some of the current industry and some of the legacy health systems is the change management piece. New people coming in don't have the decades of history of how we've operated in the past. And so they're able to come in and we are now able to be very agile and nimble and to accept that and try to advance our new work while we're changing some of the old work together. I go back to look at some of the simple stuff, right? So your GPS, that's AI, that redirects you if there's an accident and traffic is red on one place, it takes you around. And when you watch Netflix, it processes the things that you like and it suggests things to you. And we have that ability in medicine if we're allowed to let go. And there's some regulatory aspects that I think are really important for us. There's also some protection aspects with some of the associations that will allow to put some of this intelligence. I was speaking last year with Russ Branzel from Chime, and one of the things that I think is actually important, artificial intelligence, AI, he said, I call it advanced intelligence. Because some people do have the interpretation of artificial, it's not real, it's kind of real, but not real. It still has some fakeness to it, but it's not. It's actually advanced thinking being applied. So for me, I'm a big fan of both of those in progressing and moving forward.
Yeah. Let me discuss one more chart, and I'd like to start with Michael on this one. Care management. And the first thing that struck me about this benchmark chart was that the middle bar is higher than the sidebars on almost all of these. high-value care management opportunities. Michael, let me start with you. What are your thoughts?
I think this is actually a perfect reflection of how we get reimbursed for healthcare in the United States. Most of us are, and I can't speak for folks like Craig and Tim, who are a pay provider, have their own insurance arms. Folks like the University of Rochester, about like 90% of health systems in the United States, we're still fee for service. And so things like mental health, being a mental health clinician myself, we know that that is really, really important. But we don't make money in mental health. We lose money in fee for service. We know they're ripe for disruption for digital health in that area, but we haven't really started shifting our resources over there yet, because we're not in kind of a capitated reimbursement. And I'm looking, home health is another, prime example. We know it's going to be really important moving care to the home. But the way my health system and most health systems make money is by keeping our hospital at 110% occupancy and keeping that ED seeing patients and keeping my surgeons seeing patients in person and doing high cost procedures. So I think this is a perfect reflection of we know what we need to do and what's important to just do right, but of just how we get paid right now.
Yeah, yeah. And Karen, I know Geisinger has done some remarkable work in the remote management, the chronic disease management space for diabetes, the fresh food pharmacy, and so on. What do you make of this chart now, especially considering you have a health insurance arm as well as a clinical enterprise?
So I agree with Michael completely in that in order for us to advance digitally in these areas, we need to have value-based payment. Geisinger is fortunate enough that we do have a health plan. So we are incentivized in every one of these areas to really double down on the technology, and not technology just for technology's sake. The reality is many of these problems, such as behavioral health, chronic disease management, we've thrown a lot of resources at it, but maybe not doing such a great job in terms of what the outcomes have been. So for, I think, the industry as a whole, I think Michael raises a huge issue in that the divergent of those that are at risk and those that aren't. And if you are on a complete fee for service schedule, it's very hard to empty the beds and keep the lights on at the same time if you have everybody going home. So I think in addition to implementing these technologies, I think it also is imperative that we do legislative advocacy to move faster to a value-based system. I think we lost, if we gained 10 years moving forward on the digital front, we lost a couple years during the pandemic of movement to value. I think I was hoping by now that we'd see many more commercial payers, and along with Medicare, advancing very quickly into the value space. I think unfortunately our 2020, 21, and now into 2022 has really delayed that advancement. And it's concerning to me when I look in these areas.
Tim, Craig, any thoughts?
I would just reaffirm what they're saying. I mean, it's absolutely true. I would say a couple other data points. Obviously, having come from a large payer before this and focused a lot on trying to enable technology and drive collaboration, and we'll say more true upside and downside risk, and the fact that the top payers would argue that they have a very high percentage of value-based contracting, we know it's not true, right? It's not true value-based contracting in terms of true upside downside. And so that doesn't help to keep on trying to say that we're doing all this value. 80% of our members are under value-based contract. I mean, they're just not that in terms of a way that it's encouraging and driving this. And one of the things I was surprised about as I'm trying to see both sides of this world in my new environment is that basically on a given year, we at a max 18% of the provider services we get paid for are to our plan members. So only 18% do I actually control on the plan member side. Some of the largest payers are still my fee for service world or pseudo risk world that they're talking about. And so that absolutely needs to change. And I'd say part of the problem is sophistication on the provider side and their reluctance around taking risk or understanding how to take a risk in a business manner that the large payers have been optimized on and really well armed for. That's made this unbalanced as opposed to looking for a win-win in terms of what's the overall approach to the best outcome at the most affordable cost for the end member patient, as opposed to the battle about who's going to win in this supposed share of risk.
Yeah, I'll comment as well. So I think, I don't know Michael's background, but he said he's clinically based in the mental health area. And it's quite obvious because he's pretty blunt in his comment, but he said it in a nice way. So it was very receptive, but I think he nailed it. And Karen and Tim certainly supported the comment on that. It's how we reimbursed is how we're driving some of this. I do think for many of us, if not most of us, we've been talking about it for nearly 2 decades, the whole value-based world. It is time for us to continue to push hard and to go at risk and to make that transition. It's a big part of Intermountain Health is to be the value-based model moving forward in all different types of markets. That's why we're pretty diverse with how we're spread out in the 8 states with very heavy urban, heavy rural, competitive, non-competitive. And it is our goal to be able to prove success in this manner and to be able to provide a higher quality, higher valued, lower cost, increase accessibility, increase affordability in all the different markets that we're able to serve. So I find this very similar to the other 3 panelists, but I do think that hopefully many of us as leaders can start that transition and continue a more aggressive, accelerated approach. Because for me, it's more about my children and my grandchildren. What type of healthcare system am I leaving them? And the ones that we've had in the past have not been optimal for us in terms of quality and cost and affordability and accessibility. And so it is time for us to, as an industry, to make that shift and make that change. Remove some of the competitive nature and make it a little bit more collaborative and really move when we discuss with payers, either our own or others, just push that value proposition and make it successful because we can do it.
Oh, thank you for those really thoughtful reflections. I want to cover one more topic, which is around governance models for driving digital transformation. This is something that personally I follow and I pay a lot of attention to, because we see a strong correlation between how an organization is set up to drive digital and how much progress they make with digital. There's a lot of things bundled up in that. So in our assessment, in our award submissions, as well as in our assessment, we ask questions about how organizations are structured. Do you have a dedicated digital function? Does a digital leader report to the CEO? When did you formalize it? And so on. And you can see some of the charts here. Love to go around the panel and ask for your thoughts on what you've seen as best practice. Let's start with you, Craig. You're now bringing 2 organizations together. So you arguably you have a more complex task in front of you than potentially others, because you're bringing 2 organizations, 2 different EHRs. Talk to us a little bit about how all that looks in your role.
Yeah, when I look at this, probably the biggest surprise for me is that still a third of our industry or a third of our organization doesn't have a digital focus, which is surprising. I really would have thought by now, most, especially through COVID, that would have experienced that in order to be successful, in order to maintain a margin, that this transition needed to take place. The thing that I would say is, I'm not too concerned about the reporting aspects of where a digital leader is, nor am I concerned if it's separated, or in my case, it's the Chief Digital and Information Officer. I think many of us, as historical CIOs, digital was always in our in our scope anyway, just like analytics and data and all those pieces. Sometimes it's a formalized title, sometimes it's not. We had an instance in first coming into the merged organization. We had a consumer aspect that had components of digital, and when that person left the organization, those responsibilities then became part of this role, and that was to me as a natural evolution. I think continuing to advance that aspect of it. For me, what we've seen over the last couple of decades is the change from a technology leader, whether it's an analytics officer, a data officer, a digital officer, an information officer, combination or separate, is moving from finance, where many of us started. It was all about controlling expenses, making sure we don't spend too much, to operations, where it was how do we enhance the workflow, get some efficiencies, get some satisfactions. And now it's true to strategy, which is either within strategy or within the CEO, depending on your organization and how you are really organized. And is your CEO more external facing, and or is he or she focusing a lot on the strategic aspects of the system? So for me, that transition has happened, and it has to purely be in the strategic piece. You don't forget about the other two. Those don't go away. You still got to be very efficient. You still got to manage the workflow and the operations. But now you're a differentiator. You're a reason why a patient or a member or a consumer is going to choose your healthcare system versus another healthcare system, or versus some other alternative way to get service. So I think this aspect of the strategy part of moving the digital and the information and the analytics, in addition to the other two, adding that strategic aspect for me is really the important part of the evolution and maturity of the role.
Anyone else? Karen, I've had the good fortune of working with Geisinger, so I know a little bit about this, but I'd love to hear your thoughts. Geisinger has been at this now for several years, and you've seen quite a few iterations of the governance model as well. So I'd love to hear your thoughts.
So I think the most important part, to Craig's point, is culturally. You have to believe that digital transformation, and I always say transformation because building on earlier comments that we talked about, is that we don't want to digitalize existing processes, right? So this work requires considerable resources, and I think it is important. You might not have to report to the CEO, but I think it's very important for the governing board and the executive, the C-suite, to understand the value, so that when it comes time to really allocate resources, that you can execute in a way that's successful. I think it is imperative that it comes from the governing board, really down to the business unit.
Tim, any thoughts? You're relatively new to the role, so you have an opportunity to shape a lot of things, I imagine.
Yeah, well, so I created a chief digital officer role within the first 6 months of joining. And that wasn't because the organization didn't have the concept of a digital function or the digital concept. The previous CIO for 3 years before I joined had a consumer digital program, official program that was, unfortunately, primarily technology or IT led only. And it was once again focused in a narrow scope around, we'll say, mobile apps and portals and things like that. So I think, the comment I would have is on a broader stage is understanding what digital is and what digital is defined to everybody to be consistently across the C-suite and the rest of the organization, because it means a lot of different connotations to people when they say, hey, do you have a digital function? Well, they all come in their mind with something very different from what they think that digital definition is. And in terms of organization and governance, it really depends on how well your culture, as Karen's saying, and how well you're good at executing from a matrixed environment about what that organizational structure needs to do to get the alignment that you want within the organization. But I think more broadly, I'd take a step back and say, how do we, after we define a common understanding of digital, how do we make everybody understand that everybody has a contribution or responsibility for digital thinking, right? And so how do you get the organization as a whole to think digitally? And that's different than saying, hey, the CIO is bringing digital tech to the world. That's completely different than the digital thinking and how that operation evolves based on the leveraging of that technology. So it'd be no different than, because I just had this discussion since we're celebrating Cybersecurity Awareness Month, about this discussion that a lot of the rest of the organization says, oh God, thank God I don't have the cybersecurity problem. That's IT's problem. I'm glad that's not my problem. Like, no, that's everybody's engagement, everybody's problem, right? And so to having that embedded in the fabric of the organization, I think is even more critical than exactly who reports to whom.
Yeah. Well, we're coming up to the top of the hour, and there's some questions in a Q&A, and there's one that I'm going to pick because we've not had the time to discuss that, and very important, data. How do you plan to use data to help patients understand their potential health risks in future, and how will you deliver that information to the patient? I'd like to expand that to a broader question on how organizations are using data to really drive your digital programs. Michael, why don't we start with you, and then we'll go around the panel in the remaining few minutes.
I think that's the key to all of this. It isn't any of the technology that we roll out that's going to be successful. It's going to be the data behind that technology. I mean, it's the prime example with e-commerce and Amazon. It wasn't the website. It's all the data behind it that allowed Amazon to develop their patented recommendation algorithm. For us, alongside our digital transformation strategy, actually in parallel, follows the same timeline as our enterprise data warehouse strategy. So breaking down those data silos and making sure all this new data we're collecting from this technology flows into one place. The secret sauce for us at Rochester, however, the data piece that's probably we found most important is our patient-reported outcome data, actually hearing from the patient's own voice of how they perceive their physical, psychological, and social health has been more powerful than most other data points that we've found. So yeah, data is, to us, going to be the future.
Wonderful. Others? Any comments? We have a few more minutes before.
Yeah, I can chime in. I think Michael said it well. I mean, data and digital, that's it. So I've been blessed with a VP of Digital Services, Mona Bassett, and a VP of Data Services, Nick Iannone. We have a Chief Analytics Officer, Albert Marinas, and we actually have a meeting tonight to talk about this whole new large investment that we have that started last year that we're repurposing and bringing it all together in a modern to be able to present to our senior team and to our board. But they're hand in hand, they're neck and neck. You can't have one without the other. It's just tied so close together. And I think that's maybe some of the downfall for people in the future is if they have those responsibilities separate, they've got to be intertwined into the programming so that all that kind of feeds together in the way that it was talked about how some initiatives are lining up. That's exactly what it is. It's a roadmap that really takes advantage of data and digital and bringing it all within one program to be able to get back out for the caregiver, for our patients, for therapeutics, whatever the different pieces are. That to me is king, and all decisions and direction really should be made based upon that.
Let me throw in one more concept here, Tim. I'd love to hear your thoughts. Cloud, in the context of data analytics, cloud-based models. And I know you've just appointed a chief data officer as well. So give us your thoughts.
Well, yeah, I mean, that's the progression. Just 4 or 5 months ago, brought in finally after searching for the right person for a chief data officer. And it's not so much about saying this one person magically solves your data problems. It's about the organization giving the commitment and validation and visibility to say that data is meaningful, data is an asset, and data is something that we're not tapping the value into, both the fumes created from our operational systems and our standard foundational reporting that we have to do, but more advanced utilization of that, injecting, as Michael said, the consumer self-generated data as well as other external data sources that are all important to understanding how that goes, and getting that foundational leader to take it seriously as an organization, to create a serious governance model, to take seriously the level of quality, because all this data we all have tons of is of no value if you can't rely on the quality of it and the attribution of that data to the right people, right? So those things are all, I think, really important pieces of that journey, and which we're going to rely on significantly on being able to fuel all these other things we want to do, and to make that interaction experience. Because if you can't create the right personalization, so that the feeling that people, whether it's a member or a patient, feels like we know them, we understand them, we can also be seen as a trusted agent to use that data in an ethical way to help guide them and make them feel like we're giving them more benefit out of it all. I think we're going to have a real challenge with getting over that hump of just not just being trusted, but the next piece of this, which is most critical, around securing it in such a way and getting the a consent trail that allows consent to be applied to segmentation within that data, which is really complicated. And some of the things we're doing with some consortiums around blockchain are important. You mentioned cloud. Cloud just opens up the ability to do all this in a much more ubiquitous way. And so, getting us to cloud with, close to the 85% level across all our environment, across all our data. You're aware that we're hopefully in the next 3 or 4 weeks going to be announcing a for-profit IT cloud services organization that we're spinning out from our IT organization to help other health systems and other healthcare organizations get that cloud journey foundational out there, so we can have more of that benefit. We're super excited about that and super focused on the belief that that's going to help untap a lot of areas that aren't being fully utilized right now in the healthcare ecosystem.
Fantastic. Well, I guess that's all the time we have today. We're at the top of the hour. I want to thank the panelists one more time for your participation and for your wonderful, thoughtful comments. And we look forward to having you back again sometime in the future. All the very best, and we'll be in touch.
Great.
Thank you.
Thanks, Patty.
Thank you all, everyone, for joining. Bye now.